Good morning, everyone. Welcome back on this first day of October. We are so thrilled to have you all. Today is a session I've been really looking forward to. I have some of my heroes here with us today and thrilled to share them with you all. This session is going to be focused on therapeutics, and I think it's worthwhile just bringing up the framing of therapeutics in this moment. You know, there's been a lot of focus on vaccines and vaccine development, and obviously this is a critical area. But therapeutics have also played a critical role, and there's been a lot of discussion and unfortunately also a lot of misinformation about therapeutics at this time. And so we have three phenomenal speakers who are going to be joining us today. Before we kick off this event, we'd like to bring in our two poll questions. And so I'm going to ask Ivan to put them on the screen for you. They're in line with today's session. So you'll see there are two questions here. The first is, should COVID-19 patients have a right to try drugs that have not been studied and approved by, I think that would say the FDA there. And then the second is, if you were hospitalized for COVID-19, would you agree to be in a randomized, double-blind placebo trial for a promising but unproven medication? So maybe take a minute to answer those questions and think about what you would say for those. So interesting. So the first question, we had an overwhelmingly positive response. 70% say that patients should have a right to try drugs. And this will be something that I think we may touch on either directly or indirectly today, and we can certainly talk about this in the Q&A. I think the second one, there was a little bit more of a split. Still, the majority of you said that you would agree to be in a randomized double-blind placebo trial, which is obviously a critical piece of information. And we can think a little bit about this in the context of other therapeutics at other times that have come forward. Certainly, we've seen a lot more people being willing to be part of trials, both in the context of treatment and vaccines. But still a significant number said they would not. So with that in mind, I'm going to pass the baton to Alan, who will pick up this and introduce our speakers.
Thanks, Ingrid. Today's session is so important, and I thought I would just briefly mention, as Ingrid did, vaccines and how to test them, and ultimately whether or not they work has gotten a lot of attention. But the attention to issues of therapeutics, perhaps less so, except for in the instance of some controversies of proposed therapeutics where there wasn't much evidence of whether they were effective or whether they were safe. And when Ingrid and I were developing the course, we really had a decision to make. Where were we going to put therapeutics in relationship to vaccines? And it occurred to us that frontline physicians were seeing patients and deeply concerned about how best to treat them. And that while we all are hopeful that there will be safe and effective vaccines that have universal access, what we realized is at this minute in the epidemic, we really have to be thinking critically about how best to treat patients. As everyone in the class knows, on Tuesday, we met two people who have had COVID-19. One was never hospitalized. One spent more than 5 weeks on a ventilator and survived and is doing great. But their problem of how will I be treated? I'm sick, what can I do? And the problem for health providers, what's the best thing to do? And what do we have to offer these patients today? And what might we have to offer people who become infected? This is one of the most basic questions of the pandemic. As a historian, I'm really interested in therapeutics because it's one of the longest debates about what works, what doesn't work, and how do we figure that out? And I have to say, as I was thinking about today's session, there have now been 400,000 patients hospitalized approximately in the United States since around February 1st. 20,000 of those patients ended up in intensive care units. About 2,500 patients have been on ventilators. And today there are 6,000 people in ICUs around the United States. So we've been thinking a lot about the question of what might really help these patients. And it's both clinical care. We heard from Dr. Bidinger on Tuesday. Turning patients over on their stomachs turns out to be a fantastic clinical innovation that was achieved during this period. It has saved lives. So there are the non-specific management issues that physicians are facing in the hospitals, but there are also fundamental questions of what might really reduce the morbidity and mortality associated with the pandemic. And the three physician scientists today are really remarkable people. They're members of our Harvard faculty. They are people who have worked on issues of infectious disease and therapeutics and health policy throughout their careers. But like many people in our community, really beginning in January, but even before, they've turned their attention to trying to address this incredibly complicated and important problem of what might help people who are currently infected and suffering and facing the potentially deadly impact of the disease. So we have three really great people here today, people who I have so much admiration for. Our first speaker will be Dr. Raj Gandhi. And like many people in the infectious disease area, he's done extensive research on HIV therapeutics and treatments. He's directed major trials. And he now has turned his attention to what are some of those therapeutic strategies and how can they be effectively evaluated. He's a leader in infectious diseases at the Mass General. Our second speaker will be Rochelle Walensky. Dr. Walensky actually heads the Division of Infectious Diseases at the MGH, and she's widely known for her innovative work on infectious disease modeling, therapeutic evaluation, and innovative strategies for how we will know what works and what doesn't work. I should also say, you've probably seen her, in the media. She's been one of the most effective spokespeople about the public aspects of the pandemic and its social and policy responses. And our third speaker will be Jonathan Abraham, who's also an incredibly impressive physician scientist who's worked in microbiology and immunology as well as infectious diseases. He's been a leader in what's called the Mass Consortium on Pathogen Readiness, which was something set up through the Harvard medical system, but has broadly collaborated on strategies to develop in real time in this incredibly complex situation, effective therapeutics, especially associated with antibody treatments. So we really have such a great group today, and I'll turn it over first to Dr. Gandhi.
Great. Well, it's a real pleasure to be here. Let me see if I can share my slides. Ingrid, are you seeing my slides?
Yes, they're up.
Wonderful. And let me try to put it on one screen here. Well, thank you very much for having us. It's a real pleasure to be here. And actually, I want to say I didn't prepare this ahead of time, but the framing questions that were put to us all, I think are really, really important. And I think you'll see that at the end, I'll make a plea to say not only can we do randomized trials during a global pandemic, but we must do randomized trials during a global pandemic. But as a framing, as a frame for our discussion, what I'd like to do is take you through how many of us are thinking about treatment of COVID-19, And I'll start with a bit about the clinical manifestations. You heard about these already, but obviously COVID-19 is primarily a respiratory illness, but it has really a plethora of different manifestations, many of which we think are due to excess inflammation. So that's one of the dimensions we think about treatment in, is what is the patient presenting with. Another critically important dimension is the stage and severity of that individual's disease. Is it early in the course of disease versus late? And is it mild, moderate, severe, or critical? And only then do we really think about the intervention itself. Is one best served by giving an antiviral, an anti-inflammatory? Combinations are entering the fray. And then there's a variety of complications, some of which you've heard about. So these are the dimensions in which I would pose the problem. And I'll just say in brief, this is not meant to be a detailed slide, but really just to indicate that although COVID-19 is a respiratory illness characterized by pneumonia, it really can affect every single organ system in the body. Disregard some of the medical terms and just focus in on the fact that COVID-19, when severe, can cause strokes, can cause heart problems, including problems with the heart function, kidney failure, liver problems, a systemic inflammatory state that we'll touch on, and then a variety of skin manifestations. So it really is, in its essence, one severe multi-system disease. One of the things that we've learned about in terms of the way you approach COVID-19 is, although it's a viral infection, first and foremost, it also has an inflammatory component, again, predominantly one severe. And this was recognized in very early weeks of the epidemic when we had data out of China that showed individuals with COVID-19 who had elevated levels of inflammation and blood clotting markers tended to be the ones who did the worst. They were the ones who did not survive their COVID-19. And then in a study that was done locally at the Brigham Women's Hospital with collaborators from around the world, they looked and found that the lungs of people with COVID-19 who passed away from their COVID-19 really were chock full of blood clots, inflammatory cells, and this really distinguished it in many ways from other viral infections, even things like influenza. There is a spectrum, though, and this is a critically important point to make. COVID-19 is not one disease. It's a variety of diseases on a spectrum. It can start with asymptomatic or what's called pre-symptomatic infection prior to development of symptoms. Most COVID-19, as I'll show you in a moment, is mild with a variety of upper respiratory disturbances, taste and smell abnormalities. But in this phase, no shortness of breath, imaging is normal. Moderate disease is when the virus settles into the lungs and can cause some manifestations in the lungs, but with normal oxygen levels. And then severe and critical illness are when people are hospitalized. Now, the first data out of China really showed that at least 80% of COVID-19 is mild to moderate of those who become symptomatic, and about 15% is severe, and about 5% is critical. I would say now we have a recognition that some individuals never even become symptomatic, perhaps 20% in some series, maybe more, but this is the spectrum that you'll see. So this is the frame in which I would like to situate treatment. On the top, you'll see the spectrum from asymptomatic all the way over to critical disease. There are good reasons to think that the early manifestations of COVID-19 are driven by viral replication, the SARS-CoV-2 virus rampantly replicating, running out of control. But there are also good reasons to think that the critical disease phase is, the hallmark there is excess inflammation. And the reason why that is so very important for treatment is because the treatment you deploy depends in part on the phase of the disease. So we have good reason to think that the antivirals, and we'll touch on them, at least one in the course of this talk, will probably work best when people are early in the phase of their disease. Dr. Abraham will talk about antibody therapies. I won't cover that here, but they too probably are going to work best in those early phases of disease. And then later on in the course of the disease, we anticipate that anti-inflammatories will work best. And I'll show you some examples of how we've gained some knowledge in this regard. So let's start with the antivirals, and I won't go into great detail here. Happy to come back to this during the discussion. But I will say there are essentially three phases that the virus is being targeted. The entry of the virus itself, and when Dr. Abraham talks about antibodies, I think he'll harken back to this. The virus maturation, all of you I know have heard of the drug hydroxychloroquine, and that's thought in principle to have an effect there, although there are data not supporting that as well. And then remdesivir, which Dr. Walensky will talk about in some detail, works on the replication, the virus replicating itself. So we can't give a talk about therapeutics without saying a word about hydroxychloroquine. This really started with single-arm studies and observational cohorts. I would love to talk in the discussion about some of the limitations of some of these studies. But in February, March, that was the focus, is these data that were from sources that ultimately can't be definitive. And it was really only in the months of May into June and into July that we had randomized controlled trials, which are able to really suss out whether a therapy is or is not helpful. And again, in the discussion, we can come back to why that is. But in preventive therapy, hydroxychloroquine was really found to be no better than placebo. In early treatment, hydroxychloroquine, again, was really not distinguishable from placebo. And then in those hospitalized patients, and these were the people we were seeing at Mass General and in the Boston hospitals in April and May, also hydroxychloroquine really did not have a benefit as compared to placebo. Let's say a word about remdesivir, a drug that I anticipate you've also heard about. Again, this is targeting the viral copying enzyme called RNA polymerase, and therefore preventing the virus from replicating. This is a very good example of the point that I made earlier. You can do a randomized trial in a global pandemic. This is the Adaptive COVID-19 Treatment Trial, Act 1. It compared remdesivir to placebo in hospitalized individuals. They enrolled over 1,000 people in approximately 2 months. And what they found is that recovery was more rapid in the group that got remdesivir than in the group that got placebo. It's not a massive effect, but it is an important effect of remdesivir. And then the last example I will give, harkening again back to our treatment paradigm, is the issue of steroids. This is the first and thus far only drug to show a survival benefit for COVID-19. I will give you one bit of historical background. Steroids are anti-inflammatories, but there's been immense controversy, I would say, for decades about the use of steroids in viral pneumonias. After all, you want the immune system to also be fighting the virus. But given that distinctive hyperinflammatory state in COVID-19, steroids were evaluated as a potential intervention. And in a really, I would say, landmark study called the Recovery Trial in the UK, they were able to show that dexamethasone reduced mortality. I won't go through the details, but in mechanically ventilated individuals, it reduced mortality by more than 1/3. And in people on supplemental oxygen, it also reduced mortality, although not as much. And harkening again back to that same treatment paradigm, if you were not sick enough to require oxygen earlier in the phase of disease, here steroids were not beneficial and actually were potentially harmful. So this is where I would kind of sum things up before giving you one perspective on where we are with COVID-19 and one analogy with HIV. I would say remdesivir has shown some effect kind of in the moderate to severe, predominantly early severe disease status of the disease. And then dexamethasone really has an important role once people are severely ill, and particularly when they're critically ill. And we'll hear Dr. Abraham's thoughts on antibody therapy. So with that, I want to, one last point before I conclude is, I've been talking to you a lot about hospitalized patients, but you'll recall that at the beginning I said that the majority of COVID-19 is mild, and those people almost never come to the hospital. And so I will say that the phase that we're in right now in terms of our clinical trials is really focusing in on people with milder disease to try to prevent them from getting hospitalized. And I'm happy to talk during the discussion about some of our efforts here locally as well as nationally in that domain. So here's my summation. COVID-19 prevention and treatment requires a multidimensional approach. You really need to understand the clinical manifestations of the patient in front of you. You need to know where they are in their stage and severity. And then and only then do you need to figure out what is the optimal intervention. As Dr. Brandt said, I've been working in the area of HIV for some time. I won't tell you how long, but it's a fair amount of time. I've clocked a fair amount of hours at this point working on HIV. And there are a couple of lessons that I want to draw from my experience in HIV. The first, and this gets to the right to try question that framed this session. You know, we must never forget that the pressure to deploy interventions has to be tempered by the importance of finding out if a treatment works. Talking to some of my colleagues, being there at the time, there was immense pressure during the early days of HIV to approve and use drugs because people were desperately ill, and there had to be really The FDA under David Kessler, Dr. Fauci was at the NIH, really said we have to do comparative trials because unless we do those trials, we will not know if something works. And so drugs like Suramin, other drugs at the time, really were, pressure was being exerted to use those drugs. And it was only because of the bravery of the patients, the clinicians, the clinical researchers that we got to where we are with HIV, which is effective therapy, that really works. The second point I'll make, and I made it at the beginning, is randomized controlled trials not only can be done, but you must do them in a global pandemic because you've got to use randomized trials to figure out what does and doesn't work. Otherwise, you make no progress. And I think Dr. Khalil really put it best when he says this is the only way to find out for safe and effective treatments for COVID-19 and any other future outbreak. And then the last point I'll make, and then I'll turn it over to Dr. Walensky, is that this is very much an iterative process. With HIV, it was one drug at a time until we got combinations that reached a tipping point. And we will all remember, those of us who were there in 1995 and 1996 when that tipping point happened, but it was preceded by several years of slow, steady progress, and then the tipping point happened. The progress will be quicker in COVID-19. There are many more cases. It's an acute illness, doesn't play out over months, rather it plays out over weeks. And so we will make more progress, but we will make it fundamentally, I think, in the same way as we made with HIV. So with that, I'm going to conclude. I want to thank a ton of people. I can't fit them all on one slide, but I really appreciate being invited and happy to participate in the discussion.
Dr. Gandhi, thanks so much. I think you made such an important point because the tensions and desire to randomize and really know versus the needs of patients are a characteristic conflict in epidemics and pandemics, going pretty far back. Yeah. And how we resolve that is so crucial to the ultimate public good. So I think that this underlies so much of the important work. And how do you maintain structures for evaluation in the face of intensive patient needs? And yeah. I think you framed it in such a helpful way. Let me turn it over now to Dr. Walensky, and we'll pursue some of these themes. Thanks so much.
Great, thank you. I am just so delighted to be here. Thank you so much, Dr. Brandt, Dr. Katz, for inviting me and to be with some esteemed colleagues here. I'm really delighted. Can you all see my screen? Great. Okay. So I thought about how to frame this, and I thought the best way would be to just tell you the story of how remdesivir has unfolded. And because I think it really does speak to some of the challenges that we have had in trying to deploy this therapeutic. So to start, I can't see my own screen. Remdesivir was created by Gilead Sciences in 2009. And as you may recall, Gilead is one of the leaders in hepatitis C therapeutics. So this was originally, it was a drug that was originally designed to treat hepatitis C. It's a nucleotide analog prodrug, and it works at, as Dr. Gandhi just demonstrated, to interfere with the viral RNA polymerase. Now, it was designed for hepatitis C, and it didn't work as well as they had hoped it would. And then it was later tried for Ebola, and there was in fact a randomized controlled trial for remdesivir for Ebola. And though it worked less well than some other treatments, and the trial was stopped early. But importantly, in that trial, they were able to demonstrate some safety for this drug. So in moving forward, it was actually really helpful to have some of that demonstration of safety. And because research over the past decade had demonstrated antiviral activity both against SARS and MERS, related coronaviruses to SARS-CoV-2, Gilead early on started testing against SARS-CoV-2 in January 2020. Oh, I lost. There we go. So that was sort of the backdrop. And then on April 29th, we got our first taste of data from China that was published in The Lancet. And though, so this was a large randomized controlled trial, the problem was that it was ended early, and it ended early because essentially China started running out of cases and they couldn't finish enrolling it. And so that while the results were not significant, the results did demonstrate a faster time to clinical improvement. It was a trend with the remdesivir arm rather than with the placebo arm. So that happened on on April 29th. And on the same day, the NIH here released a press release, not data, but a press release that demonstrated results from the ACT-1 trial. This was the adaptive COVID-19 treatment trial that demonstrated faster time to recovery from remdesivir. So we had data from the trial that in China where we could actually see the data. And then we had this tease from a press release from the NIH. And that was April 29th. And the events that unfolded in the next couple of weeks, I have to say, were extraordinarily frustrating for those of us who want to use this drug. So let me tell you about that. So this was our census of patients at Massachusetts General Hospital over time. These are data that we see. Dr. Bidinger probably shared our stories of incident command and how we met every day, twice a day. But this is what it looked like on April 29th. All inpatients are shown in black. Our floor patients, our general care patients in red, and our ICU patients in blue. So we were coming down from our peak, but we still had over 300, nearly 350 patients in the hospital, all with COVID. About 200 of them were on the general floor, and about 125 of them were in the ICU. We had a lot of patients, and they were sick. That was April 29th, the day of the press release and the Lancet paper. And then several days later, May 1st, the FDA issued its emergency use authorization, allowing us to start thinking about using remdesivir for all of these patients that we had in-house. And this is how it read. The EUA allows for remdesivir to be distributed in the US, to be given IV by healthcare workers, and to treat people who had laboratory confirmed COVID-19, in adults and children hospitalized with severe disease, where severe disease was defined as patients with low blood level oxygen or needing oxygen therapy or more intensive breathing support, such as a mechanical ventilator. So for the most part, in my mind, this meant any patient on oxygen with COVID in our hospital, and that was a lot of people. That was May 1st. On May 4th, actually, our pharmacy received a phone call that said, you should get yours tomorrow. We had no way of knowing how much or that it was coming or to even be able to stop it if we wanted to. We got this phone call from HHS that said, you should expect it tomorrow. And the next day, sure enough, it arrived. Massachusetts General received 170 5-day remdesivir treatment courses. That was, remember, about enough to treat less than half. We had 344 patients with disease. And we were then assigned the really difficult task of deciding who was going to get it. And I remind you that the only data we had seen as of yet were data that demonstrated a trend, and then the data by NIH press release. So that was May 5th. That night, weekly during the surge, the chiefs of infectious disease of Boston and some of Massachusetts, not all of Massachusetts, had a weekly meeting to sort of share our experiences, trying to understand how we were tackling difficult issues. And I had a really difficult meeting that night, because that night I said, how much remdesivir did you get? And for the most part, they all got none. And so it became very unclear to us how it was allocated, why we got some, why others did not. And it was even more disturbing that BMC, who is a safety net hospital in the city, actually got no remdesivir. So as hard as it was for me to have this realization, it was equally hard for them. This then came out on May 7th, so this was 2 days later, and what became clear over the next couple of days, really because we were talking to the press, they had found out, is that the 4 places in Massachusetts that got remdesivir, in addition to Massachusetts General Hospital, were Melrose Wakefield, North Shore Medical Center, and South Coast Hospital, and to this day, we do not know why. And Ben Linus at BMC, who's one of our colleagues, said, this injustice is staggering. We have the 2nd highest absolute case count in Boston. Today, the family of a dying patient asked me why we don't have remdesivir. What is it I'm supposed supposed to say. And much to the credit of, I will say, the leadership of our hospital and of Mass General Brigham and the leadership of all of these other hospitals, we decided to give all of the remdesivir that we received to DPH, the Massachusetts Department of Public Health, so that they could allocate how remdesivir was given across the state. We felt that they had a better idea of how many patients were distributed across the state and how they could, and we were going to already have a hard time allocating it within our hospital, but we certainly didn't want to feel like we were the only ones that had it. And so we started in the process of giving our remdesivir to the state and then joining a conference call about how it was now going to be allocated across the state. It's not advancing. Uh-oh. There we go. But still what was a problem is we were now going to get less than we had before, right? And so April 29th, we saw this press release. We had remdesivir in our hands. And on May 8th, we wrote this op-ed with two of my colleagues. Alyssa Letourneau is in fact in charge of our antimicrobial stewardship. And she was the one put in charge of deciding she reviewed everybody's chart in the hospital and deciding who was going to get the remdesivir we had. And what we wanted to say is, wow, if we could see the data and say, you know, it does better in people who are on the floor in that in the viral phase, as Dr. Gandhi described, compared to those in the inflammatory phase who might be more the critically ill, then we could really allocate the drug appropriately and give it to the place that would do the most good. But in fact, it was May 8th and we still didn't have those data. We didn't see those data until May 22nd. So almost a month, I would say 3 to 4 weeks after the press release, after the EUA, 2 to 3 weeks after we received remdesivir, we finally saw the data published in the New England Journal. Those who underwent the remdesivir treatment arm had a median recovery time of 11 days as compared to 15 days for those who received placebo. So this was consistent with what we heard from the NIH press release. Mortality by 14 days was 7% with remdesivir, 11.9% with placebo. That was not statistically significant. There was certainly a comment about the fact that remdesivir still had high mortality, and it was clear that this treatment alone was not going to be sufficient. But importantly, these data from this trial demonstrated actually did more good, as Dr. Gandhi described, in those who were they were hospitalized and sick on oxygen, but they were earlier in their treatment course, or they were earlier in their phase of disease. Around the same time, the Gilead itself published their own trial that demonstrated that the 5-day course of therapy was best. So they looked at 5 days versus 10 days and demonstrated that 5 days was enough. And so that became our standard of care, where we give 5 days intravenously, 2 doses on day 1 and 1 dose for the subsequent 4 days. So that meant we needed 6 doses over 5 days. And you may wonder why I'm like counting down to the dose, but we were counting down to the dose. Like if people got discharged, we were reusing their doses because we needed every dose that we had. I don't know why this is, sorry. Uh-oh. There we go. And so fast forward now about 6 weeks, our search has come down. It's July 12th. And we're starting to have conversations about how we prepare for the fall, how much remdesivir we're going to need for the fall. HHS was asking us if we wanted and needed remdesivir. And then this piece was on CNN. And it basically was a canvassing of places that had hotspots and realizing that there were places around this country that didn't have remdesivir. A colleague of mine from IDSA called me from Southern Florida, and he said, "We don't have any. How am I supposed to do this?" San Antonio, they had 250 patients. In a 6-week period, they had remdesivir supply for 53. Houston would say they were nearly out. And so what became clear is that, and there were weekly phone calls with the HHS, Gilead is the sole manufacturer of remdesivir. It has the patent. It's the only company that makes it. On May 3rd, there were 97,000 treatment courses that were given out across the country. May 18th, another additional 50,000 additional treatment courses. And then on June 28th, HHS and Gilead reached an agreement where 500,000 more treatment courses were now going to be bought. Everything but in May and in May was donated by June 28th that was going to be bought, and that the US had bought 90% of Gilead's production through September. We can talk a lot about the ethics of that, and that we were going to get 90% of it and the rest of the world was only able to get 10%. And ASPR, HHS, which is the group that is working on this allocation, basically said that they were using information already input from a teletracking portal on how they were going to distribute this. This, of course, was during a time where they were reimagining how they were tracking these data. It was initially coming from the CDC, and then it was coming from HHS, but that's how they were looking at it. And so we put this piece forward to sort of say, like, we really do need a transparent and predictive distribution method, because what was not clear is if we ask for remdesivir now to have it for the fall surge in Boston, are we actually preventing South Florida or Texas from getting remdesivir? Because we certainly don't want to do that. So we really were begging for a transparent distribution method. It was very clear that remdesivir is actually not hard to make. It's reverse engineered. There have been companies now that are making it generically in India, Bangladesh, China. They have actually plenty. Some, but not all of those are licensed by Gilead, but that was actually locking up some of the supply and the active ingredient. And then there were other places that were producing it independently, but they could offer the supply. If you talk to the suppliers in Bangladesh, they actually had plenty. And there is this concept called government patent use. It's a legal concept, and Amy Kopinski, who wrote this piece with Paul and I, actually is a patent attorney, and she basically said, why are we not using government patent use? So government patent use prevents price gouging and shortages when drugs are in short supply. They rarely call on it, but it is very much used during wartime and was used a lot during World War I and World War II. And there was thought actually that because the NIH had funded the remdesivir trial, the initial Act 1 trial, that NIH and actually the government owned part of the patent of remdesivir, and so that why wasn't the government taking control? And that the government could in fact buy the drug from any company, supply it to others, so we had plenty of supply, and we wanted to not hold Gilead harmful here and say, like, we could actually give Gilead a royalty based on this. Our goal was simply just to have enough. And so now we'll move to August 28th. The FDA has expanded its emergency use authorization. It has now, in the absence of data, I actually think, to demonstrate that we should be doing this as widely as it has been authorized. It's now authorized for adult and pediatric patients with suspected laboratory confirmed COVID-19, irrespective of their disease severity. And I'm not sure we have the data to defend that. And I think that that's partially seen, and maybe Dr. Gandhi can comment on this. These are the latest updates of the NIH COVID-19 treatment guidelines. This section was last updated on July 24th. Then the recommendation is to prioritize our limited supply of remdesivir. Because remdesivir supplies are limited, the panel recommends prioritizing it and saying it cannot make a recommendation either for or against starting remdesivir for patients who are on a high flow device or on ventilation. This is, I think that the panel has been considering this. We just heard actually in the last couple of days that HHS has heard from Gilead that they believe that they will have hundreds of thousands of doses, and they believe that they will have enough through the fall surge. I've asked them how they have projected that, because it certainly looks like we may have more cases through the fall, and maybe hundreds of thousands of doses will or will not be enough. But that's where HHS stands on things right now. So with that, maybe I will just conclude with the implications of this. What are the data for the expanded EUA? Because we are still every day reviewing the chart of every person who comes in the door with COVID-19 to see if they are remdesivir eligible and if we should use our current supply on those patients, because we are very worried that we may not have enough come the fall. Will we have enough come the fall? This is, Gilead noting that they have several 100,000 treatment courses and they expect to have enough. when we have too little supply, who should get it first, especially in the context of the expanded EUA? We have been tending to follow the data as we are able to see it, focusing on those with oxygen requirements, but not ICU requirements. Other hospitals, even in the city, are using it more liberally than we are. We devote substantial manpower to ensuring remdesivir stewardship and their drug eligibility. And how much should we request for an upcoming surge? And if we request it now, we do have remdesivir on the shelf. Who in the country will not get it? And then I think the implications of this are really far and wide beyond remdesivir, because I think it very much speaks to how we are going to be allocating vaccination in the months ahead. So with that, I will say thank you. I'm indebted. My list is so incredibly long, but I could not have lived through these last 7 months without an incredible division behind me. And I will say one of the gifts and blessings of the last 7 months have been the network of people I've met and learned from in these trying times. Thank you.
Thanks, Dr. Walensky. I just have one sort of quick question or comment to insert at this point, which is, your presentation is so interesting, and it's so rare that we get to see almost a day-to-day, week-to-week rollout of a drug, its evaluation, and then its accessibility. But I'm wondering, this is something that I think the public and even close observers don't often see, is at that moment when you move from, we know this works somewhat well, but we don't know exactly how it works and for whom in terms of how best to allocate it. Does the research really stop, or are there ways to continue to successfully and rigorously evaluate for whom it would be best? Because the questions that you raise about access are in some ways dependent on knowledge that we don't completely have. So I'm wondering at that moment, sort of how, you and your colleagues see that transition to, is this now considered in some, bimodal way an effective therapy? And does that reduce our potential to understand this more substantially?
Yeah, you raise an interesting question for sure. And I'm curious what my colleagues would say about this. I was feeling like we were too small to answer that on a day-to-day basis. We were not going to be able to answer based on the 200 patients with us, whether we should use it on people on 8 liters of oxygen versus in the ICU. That needed to be a larger scale, which is why we were really eager to participate in any of the clinical trials. One of the things that was interesting, and during the surge, we had what Arthur Kim and Dr. Kim and Dr. Gandhi led our chant calls. These were daily calls where we reviewed cases and what people should get, especially in the absence of any data early on. And what was so telling time and time again in those calls is how somebody who had gotten some intervention from yesterday would get better. And somebody who you had wrung your hands and decided to hold hands and not give that intervention also got better. And so you thought, well, if we had given that drug, we would have said, aha, see, it was the drug that did it. And so it was really telling doing that day after day to realize we need these randomized clinical trials, and things that people would have sworn in their cohort studies were the thing that made the difference were in fact not. And so same with hydroxychloroquine, right? I mean, we were thinking it was doing good. We really were. But to speak to your question, we could sort of say, this cohort of people we were looking at who were on a little bit of oxygen versus a lot of oxygen, but it was very hard to get out of the weeds and see the big picture, which is why we were so desperate to see the stratified data in the trial, to see among those strata which were benefiting the most.
That's really helpful. I have many more questions, but we'll move on now to Dr. Abraham. And thank you very much. Dr. Abraham.
Thank you. I'll just go and share my screen and make sure it's working. Okay, can everybody hear me okay? All right, let me just close this here. All right, so thank you for the opportunity to speak today. I will be talking about specifically the role of antibodies in treating infections by emerging viruses with a focus on COVID-19, also some background on Mass CPR, which is an organization that Dr. Gandhi and I are a part of, as well as multiple investigators throughout the Boston area. So this is really something that was formed early in March through the vision of the Dean of the Med School, George Daly. And the idea was to rapidly establish a consortium that would meet an urgent need for drugs, vaccines, and diagnostics to prevent and treat infections by emerging pathogens. Ultimately, we had COVID-19 as the major initial priority to tackle. And I should add that this was in early March before various strategies to reduce spread, including wearing masks and social distancing were not in place. But a few of us attending this meeting were nervous about what was coming. But ultimately, this was perhaps the last big meeting, or the last meeting actually I was a part of since that time. And so the therapeutics working group, so there are multiple aspects. I mentioned diagnostics, vaccines. The vaccines group, for example, is led by Dr. Dan Baruch, as well as Dr. Andrea Carfy. Dan Baruch is at the Beth Israel Hospital. Andrea Carfy is at Moderna. And Dr. Gandhi on this call is involved in the clinical management working group. But my group, which I co-lead with Mark Namchuk, really is focused on three areas. The first really is to repurpose currently available drugs. And what I mean by this is sort of an approach that's typically used is whereby one can look at drugs that have been approved by the FDA, say, and are known to be safe and tolerant in humans, and ask whether or not these drugs could be reused in this case for their antiviral activity against SARS-CoV-2. And so we can get into this in the discussion. There's some challenges with repurposing from the standpoint that a lot of the assays are assays we do in the lab in tissue culture plates. For example, hydroxychloroquine having its antiviral effect in a specific kind of African green monkey cell line. But ultimately, a lot of those types of approaches have not really gone through the rigorous testing that's required when we think about drug design in general, which is testing in animal models to demonstrate efficacy. And then ultimately, a longer term goal is identifying new drugs with activity against viral enzymes. So for example, there's been a great deal of success targeting viral enzymes in the human immunodeficiency virus, and hepatitis C virus, as Dr. Walensky mentioned. But these tend to be longer efforts that take years to come to fruition. And then lastly, I should add the therapeutic antibodies bit, and this falls into the category of passive immunization. And really, this is something that's been tried for more than 100 years now, really pioneered by Emil von Behring and Kitasato Shibasubaru against diphtheria and tetanus. The idea was that individuals who've recovered from infection by a given pathogen have something in their blood or they're part of their humoral immune system that can be transferred to individuals who are sick or at risk of being sick to prevent or treat infection in those individuals. And so both scientists did some pioneering work looking at the plasma's mechanism of action and defined it as antitoxins or neutralizing antibodies. And so SARS-CoV-2, the virus that causes COVID-19, has an envelope here shown in gray. In this envelope sits the viral spike protein. This spike protein is responsible for attaching to cells and allowing the virus to productively infect cells it needs to infect during infection. Antibodies can bind the spike protein and prevent it from interacting with receptors on host cells that are required for this infection step, as well as through a specific arm they have, their FC portion, recruit immune cells to help clear viral particles. And so, these antibodies, for example, are molecules that we all have in our bloods produced by our immune system, and of course are attractive targets for vaccine design efforts, as a number of vaccines work by inducing antibodies that can protect individuals from infections from viruses like influenza virus, for example. I should add that in the case of SARS-CoV-2 now, there are multiple research programs both in industry and in laboratories who are working very hard to identify monoclonal antibodies to be used as therapy. And this is to replace the immune plasma approach I told you about in the previous slide. And so the immune plasma approach or convalescent plasma is one, again, that it was even tried in 1918 against influenza virus. In 1918 and as in now, data are really often conflicting. As Dr. Gandhi and Dr. Walensky mentioned, and the importance of controls. A lot of these studies are non-randomized, non-placebo controlled, and anecdotal. And they're difficult to design as well because one, the plasma is limited in supply. There's a requirement for blood type matching. Individuals have to also be screened for a number of bloodborne pathogens, including HIV, hepatitis B, hepatitis C, syphilis, depending on what part of the world you are in, also against Chagas. And then this is a critical bit here. The plasma ideally should be tested for activity before infusing it. Now, this gets to the issue of batch-to-batch variability, meaning that if one individual survives COVID-19, they might have a very robust activity for neutralizing antibodies in their plasma, but another person might not. And we actually don't know why that is. But in instances in which convalescent plasma has worked, I could talk about an example in discussion. Critical aspect of that approach was really testing the plasma for activity before infusing it. And so, for example, there's an effort now through Mass CPR led by Dr. Lindsay Baden at, I think, the Brigham Women's Hospital and additional hospitals who are doing this sort of testing, working with a scientist at BIDMC to test the plasma for activity before infusing it into patients. But again, timing-wise, the number of cases in the Boston area plummeted by the time this infrastructure was set up. And so again, these studies are very difficult to design, particularly when we add the aspect of timing. And so monoclonal antibodies can be made in the lab, isolate from the blood of COVID-19 convalescent donors. They can be used as single drugs or in combinations as cocktails to prevent or treat infection. And these monoclonal antibodies are the same molecules I showed you in the previous slide floating around that now one can make in the lab in reproducible quantities of reproducible activity. And some places actively working on such strategies include companies like Eli Lilly, Regeneron, as well as Vir, who have now drugs in the clinic, which is quite exciting. Which is interesting from a historical standpoint, meaning that we're in a day and an age now where the technology moves so fast that perhaps monoclonal antibodies moving forward will replace even an attempt at using convalescent plasma, since the scientific community was able to move quickly to generate these. And so I think when we think about new trials, you know, this theme is something that resulted in all of the presentations is, can we identify drugs that when used early enough could prevent worsening of infection and hospitalization or death? You know, what is the therapeutic window? Is there a finite time point at which one has to intervene before it is too late? And I mean, for example, if we compare to influenza virus, the drug there, oseltamivir or Tamiflu, it's very clear that it has to be used early on to have an effect, really. Will this be the same case for SARS-CoV-2? And that has implications on how we think about allocating drugs like antibodies and remdesivir. And then, you know, probably a relationship between prevention, pre-exposure prophylaxis, post-exposure prophylaxis, and early treatment of infection, as opposed to late stages of infection, where the therapeutic approach might need to focus not solely on battling infection, but also perhaps on fighting an overexuberant immune response with agents like steroids or drugs that inactivate a number of cytokines that will be identified, for example, as critical to pathogenesis and inflammation. So it's quite complex, but I think a theme I want to get across is that time is of the essence, and there's probably a finite therapeutic window for a number of the approaches we're talking about, which is critical to sort out, and we'll only find this out by doing very careful, randomized, controlled clinical trials. And so that's all I had. So I'll stop sharing my screen now and pass it back.
Thank you so much, Dr. Abraham. I think that is, all of these talks were just, I think they wove together so perfectly. And I think we have a lot of wonderful questions for you all. I might ask the first question as we pull up our students. You know, I was really struck by all three of your conversations were describing this inherent tension between the need for rigorous science that takes time. And obviously, in this case, enough patients who are afflicted with COVID, and the immediacy of the need that patients have in front of you. And I know that that some of you are navigating that real time. And Dr. Walensky, you spoke to that inherent tension as the division chief trying to help allocate this. And then when you're thinking also about this moment of high level politicization of both messaging and also, as you alluded to, Dr. Walensky, distribution of medications. And so I wonder, just in your individual roles, how you navigate this tension personally when you're thinking about it. And Dr. Gandhi also spoke about the HIV epidemic, which is maybe the last time as a nation we faced this inherent challenge. So I might just ask you individually how you navigate this while we pull in our first student question.
Maybe I'll pick up a point that Dr. Walensky made and just expand on it and even personalize it. In April and May, there was great uncertainty about what did and didn't work, certainly in April before we had any real data. And we had these single-arm studies of hydroxychloroquine, for example, and then we had single-arm studies of a drug called tocilizumab, which was a drug that blocks one of the cytokines, one of the inflammatory mediators. And I still remember calling Dr. Walensky late at night one night saying there's a pregnant woman who has COVID-19 who is verging on the verge of needing to be on a ventilator. Should we give her tocilizumab? Who is authorized to make that decision? We don't know if it works. Who should do that? And it was very much during that chant time when we were having daily case discussions, the COVID-19 Here and Now treatment panel that Dr. Kim and I were involved with. And so it harkened me back, though, because I agonized over that decision that day. We harkened me back to a thing that's fundamental to medicine, which is the do no harm process. We don't know, and we did not know then, and that night I did not know whether tocilizumab would help her. And we ultimately did not give her tocilizumab. She got better, and she left the hospital a couple of days later. But it really, checked my own emotions as to how do we handle these decisions. We ultimately set up a multidisciplinary team that involved infectious disease and pulmonary and rheumatology because they work in this area. And we made those decisions until we got more data. But I want to make one point here about hydroxychloroquine. Observational data, you give a drug and someone gets better, is very prone over the history of medicine to errors, not just in infectious disease, actually in hormone replacement therapy, which was widely used in postmenopausal women in the 80s and 90s. We were convinced, based on observational data, that that would prevent heart attacks. And it turned out when they finally did a comparative trial that was randomized, it turned out not only to not prevent heart attacks, it actually promoted heart attacks. And so throughout medicine, not just in infectious disease, we can be misled. And unless you ground yourself in some type of science, you don't make progress. And you need to make progress in a pandemic, and you need to make it quickly. That means that we need to do these trials quickly. I think we can do it, but we can't do it without trials. And that's why I actually talked to Ben Linus around that time when they couldn't get access to drugs. And I said, the do no harm thing still prevails. We don't know if a drug works. We'll only know if it works if we find out through a trial. And that's why I slept that night, is because I realized I did not know if tocilizumab would work. And therefore, we had to find out. So I don't know if that answered your question, but.
Maybe I'll make 3 points in response. And I very much remember that phone call because we didn't know if it was going to work. So 3 points. One is the people who are doing the clinical trial are so invested. It's been months of work. They're deeply invested in it, wanting to prove that it works. And we are deeply invested in trying to make sure we're doing the right thing for patients. It's very hard to see the 30,000-foot view when you're in it. It just is, as noted, it's just really hard. The second point I want to make is I want to actually layer on 2 other aspects that have made this really challenging. So it's one thing to say, we don't know about whether this is going to work or not. We'd like to enroll you in a clinical trial. It's another thing to just, picture a room, everyone is in PPE. You're communicating, you can't see anybody's face. You can't even see if somebody's smiling. There are no loved ones around. And there's a language barrier because about 60% of our patients who were admitted during our peak had a language barrier. Now have an informed consent conversation. And it just brings you to a place where you can't touch, you can't see, you can't speak in ways that are natural to you. And it makes it very hard to even think about having, you know, what you feel to be an appropriate conversation about how to best do this. We did a lot of phone calling, we did a lot of video conferencing, we spoke to family and loved ones, but that layer on was really even that much more complicated. And then one other comment with regard to Dr. Abraham's piece, which was great, is cost, right? So we have heard that when vaccines are distributed, it is likely that they will be distributed free of charge, at least in the first couple of waves. Monoclonal antibodies are among the most expensive drugs that we have. In monoclonal antibody therapy, they can cost $100,000 to $150,000 a year. One-time monoclonal antibody doses are infusions. They are up to $1,000 a dose. If this is going to be an outpatient therapy at $1,000 a dose for vulnerable communities, how are we going to bring that to people?
Well, thank you.
Very good points. I just wanted to add, in terms of the bit of a question about the data. So I remember actually doing this as a graduate student, just doing sort of a survey to try to understand for which viral infections by an emerging agent do we know that convalescent plasma actually works as a therapy. And I was surprised. I mean, it's been tried with Ebola virus, it's been tried with Lassa virus, it's been tried with most of the pathogens perhaps that back then were making news when there were outbreaks. But I was only able to find sort of one series of robust studies done in Argentina in the 1980s where they did just that, use placebo-controlled study to show that escalating doses of neutralizing antibodies were effective. And then 40 years thereafter, they were able to do retrospective analysis to show that it works quite well, but that you have to give it within the first 8 days of illness, otherwise it doesn't work. And also that ultimately there were some complications one had to worry about over time, but these were all sort of safety parameters that were gathered because of a well-conducted study. And so I asked our collaborator in Argentina, so why don't we have something, say, for a related virus that circulates instead of Argentina and Bolivia? They said, well, they were never able to do the study. People got Bavarian, another drug, and things got mixed up. So they never were able to effectively get their act together to organize a study because, again, it's so challenging to do. But you know, without rigorous data, what my fear would be is that we wouldn't have in hand approaches that we perhaps could figure out work for the next outbreak. So we need to get this information now to prepare better for the future. Yeah,
those are all great points. I was going to bring on, Dr. Gandhi, do you want to say something before I bring on a student?
No, I was going to just weave this one bit together with a comment that I see in the chat, which has to do with leadership. And it harkens again back to HIV. We need a coordinated response to COVID-19, and we have not had a coordinated response to COVID-19. We need experts, we need people who have deep knowledge to guide the response. And I think that's what a person was asking about the treatment, how HIV advanced. It was really because there was a delay. Let's be honest. There was a long delay with HIV before there was a coordinated government response. Years went by before there was a coordinated government response. But it was when there was a attention to this problem and a coordinated response that progress began to be made. And the need is greater even now because this is much faster moving than HIV ever was in terms of its transmission. And you know, more than 30 million people in 6 months infected. I mean, that's the pace that it has to go on. But we need that response. And I think when you talk about HIV and COVID, you know, I would just say that's the fundamental to both. So, yes. How can you solve the distribution problem if Dr. Walensky is having to send it, you know, herself, or the hospital is having to send it herself to themselves to other places? It's got to, you know, this is when you need coordination.
And that's absolutely to that point that Dr. Walensky and others had to make that decision instead of it being coordinated from the government. So absolutely. I'm going to bring on our first student here. We have a bunch of questions.